So today we're going to do some talking with each other, and to lead that conversation is Allison Webb, who is a public health professional who will lead you through the conversation. There are some cases on the table that we'll be talking through, as well as some other documents to refer to. So without further ado, Allison, I'm going to turn it over to you.
Thank you. Thanks. Oh dear. I am going to introduce myself a little bit more fully. Is it on? Okay, I'm sorry. You can't believe what this console looks like. I am going to introduce myself a little bit more fully later on this afternoon, but I work in public health and I work on issues related to substance use. And I wonder if there's anyone here who's working on an MPH here at UNE. Any MPH students? Oh darn, because I did my MPH here. It was a wonderful experience. So if you're ever so inclined, I can highly recommend it. We had a conversation this morning, a couple of presentations and a conversation from two people who are in recovery from substance use disorder. And I thought what I would do is just highlight some of the themes that came out of their presentations to maybe inform your discussions today at the tables. We talked and heard a lot about the very positive aspects of recovery, and here are some of the important things that emerge. For people who are in recovery, compassion is an incredibly important aspect of the care that they receive, both from their friends, their families, and also from their healthcare providers. So compassion, language that people use is incredibly important, and also images. So our language that has to do with substance use disorder, as opposed to stigmatizing language like addict and alcoholic, is very important, and some of that will come up in your conversations at the table. Another theme that came up when we're talking with people in recovery is ask them what they want. Don't assume that you know. There are many pathways to recovery, and you don't necessarily know the path that the person who is sitting with you is on. We talked a little bit about comorbidity or co-occurring disorders. So substance use and mental health disorders, very common co-occurring situation, and oftentimes the mental health condition is masked by substance use, and when the substance use goes away, the mental health condition emerges and needs to be addressed. Talked about stigma, which has to do with language, but it has to do with a whole lot of other things as well, the way we discriminate against people who are currently using or who are in recovery from substance use disorder. We talked about the new recovery advocacy movement, which I'm going to talk about more this afternoon, how you can be an advocate for people in recovery. You can be an ally, you can be an advocate, you can be a champion, lots of different ways of thinking about your role as a healthcare provider in supporting people in recovery. And part of that has to do with culture change. So there's language change, but there's also culture change in how we think about substance use disorder, how we think about people who are currently using in recovery, and how we sort of change the conversation by the way that we talk. So if you think about the way that we talked about homosexuality 50 years ago, so that's a really long time ago, but believe me, it was pretty different then. Or if you think about the way that we talked about transgender 10 years ago. Just 10 years ago, the conversation has changed. And so we are able to do that with recovery as well, and that's part of our jobs. We talked about recovery being holistic, and there's some handouts at your table that talk about the 8 dimensions of wellness, which is one way of thinking about recovery being holistic, and again, focusing on wellness. We talked about the importance of hope and empowerment and the future and purpose. So all of these things come up when we're talking with people in recovery about their recovery. What rarely comes up actually is their substance use. They are focused on building their new lives, and that's something that you can help them with. So with that, let's take a look at at your table you should have a piece of paper that has case studies on it. Everybody got that? So what we'll do is we've got 3 case studies, and we're going to spend 10 or 15 minutes on each case study. And I'd like you to just sort of look around at your table and make sure that if you need someone to facilitate a conversation, somebody can. Might be somebody who was in the meeting this morning who's heard that information. Somebody to take notes, and somebody who will do the report out. We're just going to have a super quick kind of 5-minute popcorn report out after each case study. So if you need a facilitator, identify one. If somebody could take notes and somebody could report out, that would be great. So I'm going to read the first case study, and you'll see there's some questions associated with it, but let me just read through it. So Jennifer, so this is a patient-focused case study. Jennifer is a 38-year-old female. She comes to your office asking for help with anxiety, and she mentions that she's missed her menses this month. She's been in your office 3 times over the past several months with a variety of medical conditions, including gastritis, a fractured wrist, and insomnia. Her income supports a young family and a husband who's unemployed but is desperately seeking work. She's shared with you that she's drinking more than she should and that at times she feels like she can't stop after a drink or two and finds herself finishing the bottle. You've had conversations with her about her drinking and made referrals, which she has declined, saying, "It's not that bad, and I'm not an alcoholic." She says it's just because she has been experiencing a lot of stress, balancing her job, parenting her children, and supporting her husband during his job search. She also shares that she's been spoken to about her tardiness at her job. She's afraid of losing her job because she carries the health insurance for the family. Your lab tests show that she is pregnant and that her urine drug test is positive for benzodiazepines. So if you'll sort of think about this woman who appears before you with this situation, and look at those 5 questions. What are some of your thoughts, your own thoughts, internal thoughts? How can you manage your own thoughts about that? Do you have judgments about this woman? And how would you manage that? How would you begin a conversation with her? What might you say or what words might you use that would cause her to pull away? And what do you think might engage her? Or what terminology might you use to engage her in the conversation? So we'll take about 10 minutes, 12 minutes to talk about this case, and then I'll just ask anybody who's interested to sort of pop up and give us some feedback. Any questions? Okay.
Check, check, check. Check, check. Check. Let's see if I'm getting that. Check. 1, 2. Okay, good. So all you do is put this at the table.
Okay.
This will go to my camera, but not into the room.
All right.
So,
Awesome.
Yeah.
Should I have the green light?
It's on right now.
Okay. Awesome. Thank you.
This will have a lifelong influence.
I picked your table. All right. Thank you.
Reading through
Oh,
this. That's like the ultimate question.
Any profession.
I'm any profession you are. Sure. Profession. I'm a grad student at Mustard. I was one of the things this morning covering yesterday.
Oh, okay.
Do a lot with CCSME, young people in recovery, which is the National Grassroots Advocacy Organization, seeking to decrease barriers and increase access to treatment, education, housing, and 21 years. And I've never practiced that.
He's been on the elevator.
Yeah. Well done. Thank you.
Some of those are.
Well,
Actually, I'm from Massachusetts.
Oh, cool.
But I'm just starting my first semester here. Second semester.
I'm originally Carlisle. Well,
Not sort of south of Boston or west?
southwestish. But Reading is where most of my life is.
I have a-
Kingsbury's out by the Shrewsbury West.
It's more, well, it's 20 minutes south of Portsmouth. I mean, Portsmouth.
Hi, I'm Glenn, first year social work student. As I'm reading through the case, and specifically my internal thoughts about this patient, it might be different than some other people. As a person in long-term recovery, my initial thoughts are almost excitement. Oh, here we go, we got one. And then my next sort of thoughts are, has she tried a self-help program like AA or NA? While it's worked for me, it might not necessarily work for this person. I got to keep in mind that there are many paths to the top of the mountain, as they say. And we also talked as a group that with working with this person, two things that would be really, really important for us in order to build rapport and make a connection is to be curious and compassionate.
Thank you. Other comments?
Hi, I'm Margaret Brown, and one thing I noticed with these 4 young ladies, 3 are in pharmacy school and the other is in occupational therapy school, is that they said, what can I do for the patient? I'm not going to tell her what I think, but I want to know what she's feeling, what she's thinking. And then they talked about trying to, go through her daily schedule, because she has an awful lot on her plate to address the pregnancy. They looked at the financial piece. They were looking at other supports. But the compassion came through, and I thought that was really cool. And that's a big blessing, I think, for our young community, is that they do have compassion to go forward.
Thank you. Other thoughts, or thoughts that you had yourself about having a patient with this profile sitting in front of you? Oh, sorry. Or thoughts you had yourself, and your internal thoughts about having this patient in front of you?
Hi, I'm Leanne, and I work in prevention, and it was great to hear, again, starting out with that same compassion and wanting to help the woman feel like she has some control, and saying, we have some options here, instead of you have 2 choices, this one or that, And pick one right now. So starting off with that, but also to really to know that there's two people there, possibly, whatever you want to call it, but also to know how do you balance that there's the fetus that might be at risk, and then the mom too. So there's two things going on. So giving someone that care and compassion, but also sharing in a way that says, in your mind, you're thinking, this gal might have an alcohol use disorder or something. And so when she comes in saying, I'm not an alcoholic, how do you say it in just some words saying, well, these might indicate that you might be leaning towards having this disorder. And so that they do realize the seriousness of what's going on without labeling and stigmatizing. Because if you said, well, 9 out of 10 on the assessment, you're an alcoholic, that she would never return. So those are some of our thoughts.
And particularly pregnant women who use substances are especially stigmatized, so very helpful to have a compassionate approach. Any other thoughts? Anybody talk about SBIRT? Did anybody do a screen? All right. So was there a screening brief intervention sort of conversation? Oh, wait.
Oh, okay. So we talked a lot about using motivational interviewing at first to maybe make it's just so we're not pushing options onto that client, just kind of facilitating the conversation and talking them through what do they like about drinking, what don't they if it comes up, and then addressing it how they want to change if they do, and maybe referring if that comes up, if it even comes up, but really just putting the ball in her court and having her direct the conversation by us just facilitating leading questions. Yeah.
Thank you.
Agreed. We talked a lot about that as well. Motivational interviewing came up quite a bit. Oh, hey, Shelby. Something that came up as well is saying something that would get this woman to leave the office would be horrible, but also she may not return to any medical services. And so I know as a person in long-term recovery, going to a medical office is, a pretty big deal. It can be super traumatic, and then being met with traumatic language or being shamed. I didn't want to go to any doctors after that, and it got pushed into the realm of I needed to be 2 weeks away from being dead from a gangrenous gallbladder in order to walk into the ER. And by walk I mean hobble crawl, and they were like, oh my God, emergency surgery. 8 days later, I was released. But these interactions, not to put too much pressure on it, but to say, this can really, really make a huge difference. And so we kind of covered that a little bit. Thank you.
Well, something we didn't talk about, but which is occurring to me now, is that likely we've got 50 minutes with this young woman to accomplish something. And what she's coming and presenting is about anxiety and stress, and we need to meet that with compassion, meet her where she is, hear what she has for a story, but also empower her to feel that she can leave with a plan and some connections so that she'll want to come back and continue the journey.
Because if her alcohol and benzodiazepine use is working for her in terms of her stress, there has to be a better way for her to be thinking about it if she's going to make any changes. Yeah. Anybody else? All right, this is great. I love this. This is wonderful. Let's move on to the next one. So now we're going to shift our focus away from the patient that is before you to a colleague that is maybe beside you. So Joe is a 50-year-old male who says he's drank heavily for 30 years. He's on disability for a back injury, and he has neuropathy and cirrhosis. He takes 30 milligrams of OxyContin twice a day, and at times he's used more and he's asked for early refills. He stepped on a glass cup while he was intoxicated the other night, and he comes into the office because of pain. As the healthcare provider examines the patient's foot, you think that that person is being unnecessarily rough, and you see the patient grimace during the exam. Remember, his foot's cut and it's bleeding. When the healthcare provider comes out of the exam room, that person makes a comment that this person is more like an 80-year-old because of the alcohol and they just want more meds. You might be the nurse or another physician or another healthcare professional, and you've just heard this patient being stigmatized. So what might you say to your colleague? How would you approach that conversation? Anything else that you could do besides having a conversation? And would this be the same conversation if you are appear in the same profession with the person that has made that comment, or if you're in a different profession? So any questions about the case study? Okay, go.
So something we talked about when addressing the colleague is first talking about policy. So maybe instead of saying I felt, or you can refer to the organization and saying, when you were seeing this patient, can you show me, since I'm learning, like what policy you would address when you were working with this patient? So that way they have to examine their own actions in terms of the organization standards and not your personal standards or your personal bias towards their actions.
Oh, that's great. That is excellent. And if you don't have a policy in your organization, you got to get one. But that's great. That's great. Other thoughts?
All right, so we were talking about when would be the right time to even address that with the other practitioner, and I think we pretty much agreed that right then and there something has to be said. Briefly, very much to the point, and kind of, if we didn't know if it happened with the patient hearing some of that or catching some of the attitude, but if so, then we would need to kind of acknowledge that, I'm sorry about that, and then bring it right back to the patient. How's the pain feel now? You have to acknowledge that because it was just seen. Again, we don't really know, but definitely being direct, and then maybe afterwards following up. And definitely some training like this would be really, really good.
Yeah, I was just going to add, one of the things that we also talked about is, do you say anything to the client if they overheard the comment? And how would you say it? Because one of the things that I think about a lot is the folks that, from interning at Preble Street, I often have folks present who might have a minor medical thing happening for them, and they don't want to go and get help because they've heard nasty comments about them before in medical providers' offices about their using, about their drinking, about other things that are happening in their life. So I think it's super important to acknowledge that you have no idea what is overheard when you're making side comments, or if someone else made a side comment. I think it's super important to address the client if it seems like they may have overheard it. And acknowledge that that wasn't okay. I'm sorry. Are you okay with that? Or you just check in with them and see how they're feeling around it. So yeah.
Other comments?
There was talk about using, like motivational interviewing skills with your colleague, and wow, that was a really strong reaction. What's going on with you? And so some ways saying direct, but also maybe indirect. And at the end, we talked about, hey, I went to this really cool seminar on friendship, or whatever. So how do you, and really talking about the power dynamic, is this a colleague that is your superior, above you, or is it, that makes a difference too of, do I just not say anything, or am I subtle about it? Do I acknowledge, hey, this is frustrating that this patient keeps coming back, whatever. Yeah, these are hard, and not going, we at first started like, we're gonna do an anonymous report on you, from that like angry place to, how do we actually maybe influence this person to improve their practice?
I had an experience one time. I worked for a health system. This was maybe almost 15 years ago. So I worked for health system. It was before we had been having the conversation about substance use disorder. It's before that was really a term. It was before we really understood what was going on with opioids. And we were having a conversation with some physicians about making sure that we used naloxone in the emergency room. And there were some physicians who did not want to. And it was not a pleasant conversation. There was definitely a fair amount of stigma involved. And I, not being a physician, not being a clinician, was silenced. Or I felt, I should say this, I silenced myself. I didn't feel like there was anything that I could say, and I didn't know what the way to say it was. And I think that that probably would not happen now. Either I wouldn't be silent because I know what to say now, but also I think that our general conversation around these matters has shifted. It may not be where we want it to be, but it certainly has shifted, and that people may be at least more open to hearing from their colleagues about it. Other comments? All right, let's do the last one. Oh, sorry, got one more. Sorry.
I just wanted to add really quickly that when you're looking at his case, it appears that he's been prescribed the oxycodone, and he has been taking it. He does drink as well, so it's taking a look at his baseline, and if he had something to take for the pain that he's coming in there, he probably would. Mm-hmm. So try to remember what your role and what your job is, mm-hmm. and it's to treat that patient. And he has come in there for pain. You don't have to give him a month's worth, but how would you treat that foot pain for that time?
Mm-hmm. Mm-hmm. Right, the presenting symptom. Yeah. Anything else? Okay, let's move on to our last one. So this really is more focused towards an organization that you might be working in. So your program provides you fill in the blank services. Maybe at your table you could pick one of those. How would your organization make your organization more recovery welcoming for those who have substance use conditions who engage in your services? Think about the domains and what you would make more welcoming. So your physical space, relationships when people come in, what the general culture or social attitudes are in your organization, and what policies and administrative procedures you might have. Anybody have any questions about the case study? Okay, go.
So this table really helped me because I'm working on making my organization a recovery welcoming setting right now, and I'm struggling in some areas. Mm-hmm. I'm managing the crisis stabilization unit, and we are serving a lot of individuals with substance use disorders and co-occurring. And recently we've been struggling with how to provide a recovery welcoming experience to individuals who have also used in our unit, and how to promote recovery, but also say that this is a sober environment where we can have use in the unit. And even though people have come to try to be sober and have had some use while their mental health symptoms have become more prominent. So we talked about, or the takeaway that I'm getting from this table, who has really helped me, is framing the rules about the sober environment in a way that promotes recovery and speaking about recovery. Probably not right at intake, because people are overwhelmed, but maybe having that conversation with some rest about how, yes, sometimes people have used in the unit. That's something that we probably have to talk about asking you to leave, but we hope you come back. Mm-hmm. We believe in recovery. We know it's not a straight line, that there's a lot of avenues and a lot of ways to go about it, and we hope for that for you. So.
Mm-hmm. Mm-hmm. Nice, thank you.
So we talked a lot about language and just the comfortability of clinicians and providers feeling like they know what they're talking about, and having like any sort of posters and information right up on the wall, like here's a list of support groups or recovery centers or anything like that in the area, so people feel like, oh, look, I can talk about this here. And we also talked about there's an organization that is part of AA, and it's called Cooperating with the Professional Community. And they, if you call their office, you actually can get somebody to come to your organization and like do a presentation and talk about it. And often it's people who are in recovery, and they can answer questions in front of the whole organization. That's like, how are you treated, you know, before, and how are you treated after sobriety, and just to kind of get that information out there. And I do have the phone number, which I can announce if people want to write it down. But the person's name is Rudy, and he is running the that kind of outreach piece for Maine. And the phone number is 207-834-3504. So I'll be calling and figuring out how to get somebody to come over and have a conversation with my people.
So one of the things that we brought up was, or I don't know your name, Casey brought up was the words professional development, and maybe holding something for this whatever program or organization you have as like a professional development to teach expert things or leadership skills or listening skills from the doctor to the person who answers the phone when you call to make an appointment, because who's the person you talk to most when you're trying to schedule and tell people what's wrong is that person that's on the other end of the phone. So just talking about how it's important for everyone to learn these skills no matter what position they hold, and implementing screens in the waiting room. So using kind of the expert philosophy of screening everyone. And she was also saying that she was at the doctor's, she had an appointment the other day and there was a screen, and she was pumped that she got to fill out a screen. So yeah.
Yeah, thanks.
All right, so we talked a little bit about where we worked and how that looked, but some of the ideas that were brought in is making the environment welcoming and safe, seems safe. And also in the policy administrative part, talking about maybe even having all staff. I mean, all staff need to be aware of this. Andrew brought up trauma-informed care. But all people sharing that vision and that mission statement, maybe even going back and refocusing on why you're there and making sure that everybody is on board with that.
So we'll talk about this a little bit later after the break, but one of the things that we do know that's evidence-based for reducing stigma is education, of course, and it's education like you're receiving today, which is with people in recovery who are telling stories of hope. And so those types of trainings can certainly take place at the organizational level as well as something large like this. And certainly everybody hearing the same message at the same time, who's on the same team, can really lead to some culture change within the organization. Other thoughts? Did you have one?
I'm just going to put a plug in for low barrier services. And that's partly something that's not just within the program, but a program can be responsible for this, which is advocacy work. And as a program, if you do advocacy work that's going to support more low barrier services, then that's a huge part of making recovery more welcoming. And that means that it being welcoming to multiple models of recovery and not just a recovery model of abstinence. We have hardly any sober living programs in Maine that allow for medically assisted treatment. And so it's recognizing as an organization, what is your role in either opening your doors to that or making sure that there's more resources for folks that need those things. So I think that's another really big part of kind of like having your organization being focused on being welcome to recovery.
Interesting, that's great. Anybody have any other words of wisdom or thoughts? Well, thank you. I hope this was helpful, and I hope you learned from it.